Good afternoon, everyone. I was going to give you all a moment to stretch, but it looks like those who are still in the room are already back in their seats. My name is David Zuckerman. I'm the manager for healthcare engagement at the Democracy Collaborative, and we're a nonprofit and national leader in what we call community wealth building, which is an inclusive place-based approach to economic development that focuses on leveraging existing assets to expand community ownership for underserved residents. So I appreciate the comments of the past speaker, but I do want to talk about our frame is very much influenced by what we see as growing wealth inequality in the United States. And I think that this number, this graph is particularly staggering. It's just that 400 individuals control more resources than the bottom 185 million Americans. That's half the country. And so it kind of starts to challenge the notion that that we have a scarcity of resources. So it's about at the moment who controls them. Now, this growing wealth inequality, I think, does have dramatic impacts on health disparities, in addition to race. I don't think we can get away from the fact that racial disparities are incredibly significant and go beyond what was described in the previous presentation as income disparities. But I think what we often forget about is wealth disparities. And wealth is income is a moment in time, and wealth is kind of the compound interest of all of that over a period of time. And if we forget about that even as groups that have been pushed out of historically out of the economy are finally having opportunities within the economy, it's going to take a long time for those wealth gaps to catch up. And I think it's particularly alarming given the fact that by 2045 we're expected to be a majority-minority country, which means that the gap will be even greater. And so I think it's notable that the University of Wisconsin Population Health Institute found that people in unequal communities were more likely to die before the age of 75 than people in more equal communities. I think it's notable that S&P has said that inequality in the U.S. is dampening growth. And I think it's also notable that the fact that over time, this increase in inequality has actually increased the gap in life expectancy between those in the lowest the lowest socioeconomic bracket and those in the highest economic bracket. And so the issue with the fact that wealth inequality is increasingly being exacerbated, I think, is compounded by the fact that the primary way to build wealth in the United States is through home ownership. And that's another area in which we can see dramatic racial inequalities. And we can also see the impact of that strategy after the 2009 recession and what it meant for many communities. And that embedded within those challenges, or kind of within this gap, is the fact that part of the reason in this gap and part of the reason that the wealth gap actually between minorities and whites has increased since the recession is because of the predatory policies during the Great Recession that in particular impacted home ownership. So I just wanted to lay out a couple of those statistics that really influence the work of the Democracy Collaborative, and I think it summed up, and it was talked about at length in the previous presentation, the importance of place, and that that the racial segregation. On the left, this is the map of Cleveland. On the left, you see the neighborhood of Huff, which is a neighborhood that has in many ways been disinvested since the '68 riots. It is 95% black. Its life expectancy for a male is 64. 8 miles down the road, you have Lyndhurst, a predominantly white suburb, life expectancy of 88. And I think what's so striking about this, and it doesn't need to be, I think, harped on at length, because I've heard the social determinants have been talked about all day today, is that Huff is the neighborhood proximate to two world-class health institutions, university hospitals and Cleveland Clinic. And yet that has done nothing for that community for the last 40 years. So the Democracy Collaborative, our frame is community wealth building, and I'm going to talk a bit about community wealth building broadly, and then talk about how health systems as anchor institutions can employ community wealth building practices in their communities and give a number of examples. And so I just wanted to give the context for our work with those previous slides, because I don't think that wealth inequality and racial inequality are two areas that as a nation we're very easy talking about. It's something that we're comfortable with. And but I think together it's something that we really need to focus on more. And so our approach starts at heart with place. And often a lot of work in both healthcare, I think community development as well, it starts with the idea of this disadvantages in communities, disinvestments. Community wealth building is about building from strength. It's about building from assets. It's an asset-based approach to economic development. It's a systems approach to economic development. And also core to this philosophy is the idea of ownership. We have to create different models of ownership within community that keep wealth local, that allow for it to circulate more frequently. And I'm going to talk about a couple of these models that we see as very helpful in that area. And in that sense, it's the idea of getting multiplier. When you spend $1 in your community with a business that will keep those dollars there, how that dollar can be stretched further, how it can circulate more frequently, and how from the same set of resources we can have more impact. It also is very much holding as its frame the importance of equity and inclusion, that without this intentional focus in this area, we're not going to actually achieve eliminating either health disparities or economic inequalities in this country. One area that I'll just point out might be of interest, why is workforce one of the elements, is because frequently when we think of opportunities for jobs, we just generally do workforce development. We invest in preparing people for jobs that don't necessarily exist. It's about flipping that script, and it's about being intentional to identify where the jobs are and train people into them. And at the end of the day, it's a systems approach. It's not a one-off set of either individuals or set of policies or practices. It's really about trying to get a comprehensive approach to revitalizing place. So I'm not going to go through all of these, but I just wanted to give a couple of examples of what we consider broad-based ownership. Employee stock ownership plans or cooperatives, these are different forms of community ownership of business. ESOPs, it might be a term that none of you have heard of in this room, but there are more people in ESOPs in the US than in private sector unions, 11 million. And this is a model that over the last 30 years has become more common, and it essentially gives people a profit-sharing mechanism. Wages are higher in ESOPs. Savings when they retire are 2.5 times that of a comparable company outside of ESOPs. And in the Great Recession, they laid off less people. Cooperatives have a different model in terms of governance, but a similar wealth-building opportunity. Community development financial institutions, I think, are something that many in healthcare are becoming more familiar with as they're oriented with the community development sector. But they've been an instrumental entity for bringing finance back to lower income communities and communities of color that are missing many of the amenities that help create healthier communities, such as grocery stores, child care centers, et cetera, and really allowing for these businesses in which traditional banks, with the history of redlining, have stayed away from. And so there's been policy that has started to reorient dollars back into these communities. There's still a lot more that obviously has to be done. Social enterprises are, again, businesses with a social lens as a core component, giving opportunities to ex-offenders and returning citizens to have a chance to reintegrate back into the workforce. This is an incredible barrier in our communities that it really isn't talked about, is that there's an expectation that those returning from prison into our communities can suddenly just get jobs when many of the largest employers in our communities have provisions preventing them from even getting their foot in the door for an entry-level job. So it's about thinking about how do we address those significant policy barriers that are really impacting both economic opportunity and wealth creation. So these are just an idea. These are substantial community-based assets. ESOPs hold over 1.1 trillion in assets. Cooperatives 3 trillion. Where I'm going to really focus my comments on is the role of anchor institutions. And so I wanted to quickly, though, I'll get to that in a moment, but just I prepared this presentation more for the committee to look at it at their own time. I don't want to go through all of these details, but I think you can kind of see that Prospera is a cooperative of Latino women in the Bay Area that formed together to create a house cleaning business. Instead of your traditional house cleaning business with one owner and many people and many employees, they are all part owners. And as a result, their wages have dramatically increased and employs more than 100 people. Another example is something we call a community land trust, which is a form of permanently affordable housing that gives an opportunity for those who living there to have an ownership stake, but also allow for that benefit to be accrued to multiple people over a period of time by not allowing them to get all of the equity gains. And as you can see in this model, that there was a far less foreclosures during the Great Recession. I mentioned that. So I want to talk, though, specifically about anchor institutions, which we see as another asset within communities. And the Democracy Collaborative has done a lot of research around what we see as promising practices in this space. And what we consider anchor institutions are hospitals, universities, local governments, public schools, other nonprofit and public employers that over the last 40 years have become the largest economic engines of our communities. If you were to kind of pull back the layer of your community, I think you would see that these 4 businesses that we often take for granted or we don't think of as being really vital to the economic resiliency of our community are a good chunk of the dollars flowing into that. In some communities, those 4 businesses that I might have just mentioned, hospitals, universities, local governments, public schools, maybe a third of the workforce or more. It's significant. And it's partially because traditional corporate capital, especially in the Northeast and through the Midwest, has left over the years. And what has remained are those businesses that can't get up and leave. So if these are the dollars that are flowing through our community, if these are where the purchases and employment is happening, if the policies for trying to get to both communities of color and lower income communities are not there to be intentional, it's not going to happen. And that's kind of what we've seen as evidence in these different sectors. And so if you just take a moment to step back and appreciate the healthcare and hospital economic impact in our communities, we're looking at annually about $350 billion in purchasing just by hospitals across the country. And conservatively, because there's actually no reporting of these numbers, and this is an issue of data, is that understanding, no one's ever asked for these institutions to report this data publicly, so it's not reported, is that these investment portfolios that the healthcare systems have probably conservatively are estimated about $500 billion. And this is kind of money that's currently invested mostly in Wall Street bonds, other types of stocks and bonds, just as the idea that this is something that's going to sustain our organization when there's a really bad financial crisis. But how can those dollars be potentially repurposed to benefit our local communities? And that's the question that we're asking. We're asking, how can procurement and supply chain be a tool for economic revitalization in addition to the community benefit that hospitals do, right? I was talking to the largest group purchasing organization, and for those who don't know what that is, it's basically the buyer that facilitates most of the accumulation of most of the goods and services for healthcare around the country. They do all the contracting, and it's helping a lot of hospitals basically get, perceived to get better pricing. I asked him, what is the percentage of dollars in healthcare that flow to minority and women-owned businesses? And he said, we don't really know, but maybe 3%. I think that's a high number. There is no good data on it nationally. But if we're talking about $350 billion in goods and services being procured each year, even a small portion of shifting that, even a tiny portion, shifting that to businesses locally which when dollars flow locally, there's a multiplier effect in terms of those dollars circulating more frequently, or in particular to communities of color or lower income communities, there's really a benefit in terms of wealth creation. Hiring and employment policies. It's quite incredible to realize how difficult it is for someone in certain low-income communities to be able to even access an entry-level position at some of these healthcare systems. What would a targeted pipeline into a specific community, partnering with workforce intermediaries and community-based organizations in combination with career ladders within that institution actually do for building wealth and being able to disrupt generational poverty in many of our communities that have lacked opportunities to access? And so I think you can go down the line and look at that in different ways. Investment, like I said, $500 billion. What happens if 1% of that was reoriented to community development financial institutions? That'd be $5 billion, which is more than the entire community development block grant given out by HUD annually. So it's about rethinking how we do business. And this is a quote from the CEO, Tom Zenti, of University Hospitals, talking about Vision 2010 initiative, which I'm going to run through a couple of examples of where we see hospitals. I think healthcare in general is starting to recognize they need to go outside their walls. There's a number of policy drivers that I think are beginning to shape that conversation. I think the community health needs assessment at least is an educational tool for healthcare in thinking about what really drives poor health in their communities that they serve. I think the beginning of the volume to value conversation is shifting at the very edges, the conversation around what actually would look like to align a healthcare system to keeping people healthy rather than just putting them back together or providing acute care services. But what would it look like to actually take a community wealth building approach? To view this more as what's often is projectism, to actually thinking at scale and a systems way about what impact would look like. So University Hospitals in 2005 was going to invest $1.2 billion into its plant. Build a new hospital and other maintenance. And hospitals all over the country are building. In the recession, they were probably some of the only organizations building, and some can say that this will end maybe in the next decade or two, but for the moment, it's a lot of money flowing through a lot of communities. And they said, well, we can do this the traditional way, which is put this out to bid, get the national contractor who can come in, all of that money will flow out of our community, or we can set targets for spending all of that money within Northeast Ohio. We can set goals for minority and women-owned businesses, and we can hire locally. They didn't have to do this. They're a nonprofit entity. But they decided that as they started this project, when all of the other construction in Cleveland stopped because of the Great Recession, they were the only cranes in the air. It was a somewhat difficult process, but they also hired a third-party monitor, and they drove 92% of that money locally into the local economy. They exceeded their targets for women and minority-owned businesses, and in partnership with the mayor, this has led to a citywide community benefits agreement that other institutions have been asked to step up and sign on to. So it went from one entity, it went to this as the second largest employer in Northeast Ohio, using its reputation and its clout to drive a change in how you do business in Cleveland going forward around these major projects. Dignity Health, I think, is probably the leader in this space in the country. And I'll mention this a number of times, but Dignity Health has an investment portfolio of $8 billion. So they've decided to allocate 1% of it into a low-interest loan pool. Actually, this slide's old. It's now 100 million, not 80 million. And they operate as a patient lender. So I think there are a couple of examples of healthcare institutions lending using intermediaries. They actually have someone on staff whose job it is to put this money out on the street. And what have they done with this money? Well, they've invested it in credit unions who are more likely to deploy capital in communities of color and low-income communities. They have worked with CDFIs and other affordable housing providers, like Mercy Housing, to help do transitional housing as well as traditional affordable housing construction. They have invested in other organizations that have put that money out in microloans. They have this story behind here. You're probably like wondering, why do you have the Children's Museum of Phoenix up there as your slide? Is that this was a wandering museum who came to Dignity and said, well, we have this opportunity to purchase a school. No one's going to give us a loan. They went in with the capital, and they said, we'll give you a loan for 5 years. But because Dignity stepped up and showed that there was interest in this project, other private capital came in within 2 years, paid back that loan in full. And as a result, this area has sort of become, in Phoenix, has become a point of revitalization for that community. So there's a role here in kind of addressing a market gap by institutions providing low interest loans that will also create the conditions for a healthier community over time. And it's notable to say that this portion of their investment portfolio outperformed the rest of it during the Great Recession. And so it's both smart from, I think, a business perspective as well as from creating the conditions for a healthier community. Mayo Clinic, in partnership with the Rochester Area Foundation and other state agencies, helped create a community land trust within that community because they were finding that many of their mid-level workers couldn't afford housing, right? A basic need. And they were quitting after 5 or 6 weeks of being on the job. Now, they could have just done an employer-assisted housing program, which a number of health systems and other large employers do. But instead, they decided, no, we recognize this as a community need, and we're not going to just do traditional affordable housing, which can be rental, and therefore no opportunity to ever build wealth, and you're kind of locked into a certain set of situations, or kind of one-off single-family affordable housing, which only one person benefits from that investment. Instead, they said, no, we're going to do something that's a little different, and we're going to create an infrastructure for permanently affordable housing over the long run. And this has become the largest community-based assisted housing program in the state of Minnesota to date. Hopkins has a very storied history of its involvement with the community, and I think that this is probably not the outlier if you're talking about urban-based health systems and their relationship with communities. And step one before any of these kind of opportunities can be explored is to just build trust back with communities that don't view you in a very positive light. But Hopkins is the largest employer in the state of Maryland. It's not even the largest employer in the the city of Baltimore. And so after the Freddie Gray riots, realized the need to double down on its commitment to that community, which frankly over the last couple of decades had not been received well by the surrounding neighborhoods, who often describe Hopkins only thinking of them as a parking lot to be built on. So, but instead, to their credit, they have put in place, or the beginnings of, the infrastructure to redirect their significant economic power into that community in a much more inclusive way around building, hiring local, which is something that we're starting to see as well, a commitment to thinking about what jobs could be either set aside or could be connected to specific neighborhoods and zip codes. So in this case, they've set aside 8 zip codes that they're going to aim to hire for certain positions, 40% of those positions over the next couple of years. So they're setting public targets so that they can be held accountable, and they are moving forward in those 3 areas. I won't spend too long on this, but this is actually, I think, an interesting example of how you can kind of take the individual one-off local purchase to scale, working with a citywide intermediary, and they've had 15 anchors, not only health systems, but a part of this effort to begin to first understand where they spend their money and then to think about how it can be driven in a more equitable and inclusive way to local businesses. Last I'll talk about is a project that Democracy Collaborative was a part of, and was really an opportunity to put some of our the community wealth building approach into to implement it as part of a much larger place-based revitalization strategy in Cleveland, Ohio. And this was deemed the economic inclusion piece. And what the thinking was is that the person who was leading up this effort had kind of come out of doing the empowerment zone work in the 90s under Clinton and saw how that was completely ineffective. Because basically the thought there was that we were going to subsidize businesses that come in, they would provide jobs, and that would solve all our problems. But what was discovered when those subsidies dried up, those businesses left. So how do we build the capacity of local communities to determine their own futures, and also to anchor that capital once you drive in new resources into a community to ensure that those long-term residents actually benefit from it? I think that is at least what we see as one of the biggest challenges of this work, is the tension between place and people. I think if you look around at a lot of urban cores that have seen significant capital flow into it, it has not been to the benefit of the communities that were once there during the years of disinvestment. So this is just to show what this model looks like from the way it was conceived, which was the Evergreen Cooperatives are new startup businesses that meet the supply chain needs of the Cleveland Clinic and university hospitals. So they're meeting a business need. They exist in the marketplace. They do it at cost. But the goal here is to hire from specific local communities, and those communities were the ones that I kind of put up on the map much earlier, the greater University Circle area, that are predominantly African American, area median income under 20,000, high rates of people with criminal records, a number of challenges and barriers to traditional employment and economic opportunity, and to also give them an opportunity to build wealth through profit sharing in these businesses. And to date, the idea, though, with this was that we're going to put in place an entity whose job it is to create new businesses over the long term. It's not going to be a one-off mechanism. It's going to be the hope to create a new economic engine within these communities that can work with a new set of partners and really bring together the city, philanthropy, anchors in a much more collaborative way for the benefit of local residents. Tremendous amount of challenges, but 3 businesses are open that employ more than 120 people today. I think this is just a slightly different approach. I won't go into it too long, but this is another way of thinking about how, in a more rural setting, how can you create a thoughtful, integrated, collaborative model for creating a local food system that treats everyone that ensures that the wealth created is more equitably distributed among the different players in that model. And it's a model that's been it's been in production for the last 5 years. It's called the Fifth Season Cooperative. And really one of the primary anchors was the Gunderson Lutheran, which is a health system in La Crosse, Wisconsin, who is really at the table, along with school systems and a university, to kind of seed this effort. So this is kind of what we view as the areas where these institutions could be thinking about as they deploy their assets. It's what we call the anchor mission. This is the anchor dashboard, but what we call the anchor mission is kind of how do you deploy all the intellectual and economic assets of an institution in an equitable way to benefit the local community. Not in the sense of putting that institution out of business, but in a way that is simply more thoughtful. And I think what we've seen, and this is a slide, this is something that we put out in a recent paper called Can Hospitals Heal America's Communities? And this was in partnership with Kaiser Permanente, who says that, I think community benefit, or the benefit that healthcare creates, is often viewed as siloed from the organization or the operational activities of that organization. And so if community benefit is at most 5% of the total economic impact of an institution, what about the other 95%? How do we move from just simply doing good things to making an impact to eventually being accountable in our communities for all of the impacts our institution has. And that's obviously not where we are today, but that's where we aspire to be, and to push our largest economic engines to be there as well. And this is something that actually Kaiser is developing, which they're calling it all-in for mission. And they're really thinking about how all of these different areas can be deployed for the benefit of the community. And that doesn't necessarily take new dollars, it just simply takes a new lens through which to look through what the benefit of these resources can be. So where do we think this is headed, since I know that this is a committee looking at community-based solutions? And we do think there's a lot that can be done at the community level, and actually what we're most excited about at the Democracy Collaborative is the way we see the community wealth building approach being adopted by city governments, by foundations, by anchor institutions as an approach that they think can really serve their local communities. And to be frank about it, it's partially because many of the other solutions or perceived solutions have not been successful. The strategies that have been tried in the past have not worked at really addressing the massive gaps in resources between certain communities that are often being created over the years because of both racial inequities, and especially in our urban cores. So we see this as a way to begin to create basically a new ecosystem for economic development, community development, and healthier communities over the long run within the United States. And it'll have to grow from the local level. It can obviously be assisted by state and federal policy. But that there is really a lot of work that needs to be done simply in just forging the relationships that need to be created in order to begin to align policies and practices to actually accomplish this. So quickly, lessons learned, and then I'll wrap up because I think I have a minute. And is that for health systems, I think there's a number of reasons we're starting to see them across the country adopt this anchor mission approach. And I think first of all is the understanding of the social determinants of health is really something that institutions are beginning to recognize. But there is also a need to recognize that health systems are often the largest employers in their communities, and that requires a new set of responsibility that maybe large corporations once held. Health systems can no longer sit on the sidelines in terms of their civic responsibility, partially because community and local government is expecting more of them, especially since they don't pay taxes, many of them. 80% of them don't pay taxes. So there's just a new set of obligations created from this kind of combination, these three factors. But there's also, I think, a fallacy in some of this work around creating opportunities that this idea of trickle down, I think, has been one that's existed in more than just national economic policy. It's one that I think exists in most either philanthropic or other kind of interventions. But if we want to really get at equity and inclusion, there needs to be an incredible intention placed on that. So culture change, and I think one of the areas that we require this intention is that if we're talking about culture change, that leadership can buy in, but then it needs to trickle down through many of these massive institutions in our community that don't necessarily value this approach. And I think the others kind of speak to themselves. And one thing we have to stay away from, I think, is to say, oh, we've been trying that approach for 5 years and it doesn't work, and completely dismissing it, instead of thinking about, well, are we actually really deploying that approach in the way that it needs to be done to actually have the impact we want to see, or are we only doing it in the margins? So that's kind of our focus at the collaborative, is to say you really need to build an ecosystem. You need to internalize many of the factors that have been externalized over a long period of time. So I'm going to stop there since I'm over. The red light is blinking and it's late in the day. Appreciate all your time, and happy to take any questions.